When patients attend a health screening assessment through Bupa clinics, if they are over the age of 40, they will often have the option of requesting a mammogram. Unlike most other countries, the United Kingdom offers routine mammographic screening from around the age of 50 up until the age of 70 every 3 years. Moderate and high-risk patients are offered early screening, often through regional screening units and genetic services. Typically, patients at higher risk are identified based on their family history. These individuals may be offered annual mammograms from the age of 40, while those at very high risk may also receive MRI screening starting at a younger age. When conducting a health screening assessment, it is crucial to understand the patient's underlying risk and to be able to interpret mammogram reports accurately. This ensures appropriate reassurance for patients, or timely referral when necessary. A breast cancer risk assessment evaluates factors such as the patient's age and lifetime exposure to cyclical estrogen, which is influenced by the age of menarche and menopause. Interestingly, the risks with use of contraceptive pills is small and may not be significant with modern types of pills. Breastfeeding has a protective effect. A history of previous breast biopsies may indicate higher breast density. The impact of hormone replacement therapy, HRT, is covered in a separate presentation. Family history, particularly maternal family history, and Ashkenazi Jewish ancestry is a significant risk factor. It is essential to inquire about a patient's family history of breast and ovarian cancer. Resources such as the Tyrer-Cuzick Risk Calculator and NICE guidelines help determine whether referral is appropriate based on increased risk. Risk is generally categorized as high risk when lifetime breast cancer risk is above 30%. In such cases, enhanced screening, risk-reducing medication such as anastrozole, and risk-reducing surgery may be considered. During examination, clinicians should assess for lumps or swelling in the breast, upper chest, or armpit. Skin changes such as puckering, dimpling, or discoloration, especially signs of inflammation, should be noted. Subtle nipple changes, such as retraction or crusting around the nipple or areola, should be carefully evaluated. Raising the patient's arms above their head may reveal subtle nipple retraction. Nipple discharge, particularly if blood-stained, requires further investigation. Breast pain is a common symptom, though it is rarely associated with breast cancer. It is often hormonal, caused by small cysts or reactive lymph nodes. However, persistent pain, particularly if unilateral, warrants referral. If the pain differs from typical menstrual pain or if the patient expresses concern, referral should be considered. When in doubt, err on the side of caution and refer. A common scenario involves a patient over 40 requesting a mammogram, followed by a report indicating an M3 result. This corresponds to the ACR assessment categories, which range from 0 to 5. Category 0 means an incomplete assessment. Category 1 indicates a negative or normal result, and Category 2 is benign. Category 3 is indeterminate, but probably benign, while Categories 4 and 5 are suspicious or highly suggestive of malignancy. Patients with M4 or M5 results should be informed that their findings are concerning and that a biopsy is likely. Lastly, it is worth noting there may be a comment on the breast density using the letter A, B, C, or D, with D being the highest density. Radiologists will also use AI software to help identify areas for further assessment. M3 findings arise for various reasons. In some cases, prior mammograms may not be available for comparison, leading to an indeterminate result. Broadly, M3 abnormalities fall into 3 categories: asymmetric densities or masses, distortions, and finally calcifications. Further assessment of asymmetric densities, masses, or distortions typically involves additional imaging such as compression or tomosynthesis views and ultrasound. Calcifications may be benign, such as those related to blood vessels or appearing as coarse, popcorn-like, or rounded. However, fine microcalcifications, particularly in clusters, may necessitate biopsy. The majority of patients with M3 calcifications ultimately receive reassurance after biopsy. This procedure is performed using stereotactic guidance with specialized mammographic equipment, typically requiring a few days of planning. Asymmetric densities, or masses that turn out to be cysts, can often be aspirated in the clinic on the same day. patients should be informed that an M3 assessment may require additional imaging on the day of their clinic appointment. This can be time-consuming. However, most will ultimately be reassured. Clear communication is essential, particularly for patients receiving an M4 or M5 result, to prepare them for the possibility of a biopsy and further management.